ಮತ್ತೆ ಆರಾಮ?
Yeah. Were you able to download the PDF I sent you?
Actually,
I've made some changes. That's the reason.
Okay.
Howda? I made some changes, but that should be okay. I mean, I spoke on it earlier.
Correct.
So let me know if it is too long. I mean, we can skip a few things.
No.
And I will try to make
1
it
hour, 1 hour, 15 minutes is
however you
okay.
want.
Yeah, 1 hour, 15 minutes is okay. Yeah. Hello. ಅಕ್ಕ, ನಾನೊಂದು ವೆಬಿನಾರ್ ಹಿಂಗೆ ಮಾಡ್ತಾ ಇದ್ದೆ. ಅದು ಅವಂಗೆ ಹೇಳಿದ್ದೆ ಇದು ಮನೋಹರ್ ಹತ್ರ. ಎಂತ ತೊಳಿ ಗೊತ್ತಾಯ್ತಿಲ್ಲ ಮತ್ತೆ ನಾನಾಗಿ ಮತ್ತೆ ಕೇಳೋದಿಲ್ಲ. ಇಲ್ಲ ಅಂದ್ರೆ ನಾನು ಅವನ ಹತ್ರ ಏನಾಗಿ ಫೋನ್ ಮಾಡ್ಲಿ ಹೇಳಿದೆ. ನೋಡು ಕಳ್ಸಿ ಅಕ್ಕ ಮತ್ತೆ ಮಾಡ್ತಕ್ಕ. ನೆಟ್ವರ್ಕ್ ಉಂಟದ ವೈಫೈ ಮೊಬೈಲ್
Irede tuver. Tulu is a wonderful language, actually. I love it.
Tulu is a wonderful language. It connects people.
Yeah,
it does. It is like Malayalam for Keralites. Oh, Malayali ono. Whole scenario changes.
Yeah.
Then otherwise, how is it there? Now I think you are in this thing, no? Declining mode.
Yeah. I mean, hopefully it continues. We've been here 4 months now.
Correct. But soon, in another 2-3 days, we will be number 2 in the world.
I hope not. I hope we don't. I hope it declines there too.
No, it will take another 1.5 months to start declining.
I see.
We were supposed to peak now, but we have not peaked yet. So maybe by September end we will be peaking, and then it will start declining.
Okay.
Yeah.
That's good. By then the rains would be over, right?
Yeah, by then rains would be over. Correct.
That will be nice.
Yeah.
Parents are stuck at home for 3 months, 4 months now.
Correct.
At any time you think you have one particular area of questions, as I said, we can change it.
Yes, definitely. Anyway, I've kept 2 people.
Can't hear that.
this thing to see the YouTube. This thing. Then ask somebody to get that laptop. Then all our outsiders have not joined it, I think.
Does this have pointer? Google I've not done. I mean, I've done a lot of Zoom.
Okay. Pointer is there in this.
Let's see.
Yeah.
Looks like it.
Now, when you present your PPT, there will be a pointer.
I see.
Yeah.
So the other phone number was Dr. Joyce's phone number.
Yes. Yeah. Which one?
Okay. Somebody sent me a text just now in that.
Yeah. All the best. Something.
Yeah.
Yeah. That is Joyce. Yes.
What is that 55 and 57? It is how the lecture hall thing happens, is it? On the seat?
Yeah.
When
that
you're
is
sitting 55 and 57?
Correct. That is basically, I'm in the IT cell. So the connection number for that. Yeah.
I see.
Otherwise, it will come, the individual name, it will come. Yeah. This is actually wired net connection, so that there is no disruption. Yeah. Otherwise, Wi-Fi and data plan and all those things, sometimes it gives problem.
Yeah.
So Ashraf and Kishore has conveyed regards to you.
Yeah, Ashraf sent me a text.
Yeah. I had forwarded them the brochure. So Ashraf told me if possible he will join, but he is a busy practitioner, no?
Oh. Yeah. You guys are all busy, You're all combined, right? All three of you do.
Correct. Yeah, no, actually, I go to Kishore's clinic. I used to go to Ashraf's clinic, but now it's on Mangalore clinic. After this, yeah. For his delivery clinic, my assistant goes. Dr. Gopinath on staff is there. He's from Abhishetty. He goes there.
I see.
Yeah.
That's nice that you all keep in touch. So.
Yeah. That is very important. In fact, that is the beauty of Mangalore actually. Unlike in other places, we don't have any ego or any clash of issues.
Yeah.
So, whichever patient comes to you is your patient. Whoever goes to others are others. So, at the end of the day, correct. So that is why idea in Mangalore is very strong.
Nice.
Yeah.
Nice. I wish this did not happen. You had a successful conference,
Correct. Yeah. And for a beautiful conference actually. But anyway, next year it is there.
So you're postponing it to next year, is it?
Next year, happen. Yeah, it will still happen. Because otherwise this will be a problem actually for everybody. That is all my thoughts.
Good morning, everyone.
Amit.
Hi, Srini.
Hi, Amit. Good morning to you.
Good morning.
Nice to see you.
Yeah, same here. I had some issue with my internet connection on my laptop, so I'm joining in from my mobile.
Sure. Did you get the updated one?
Yes, I got it. I got it.
Yeah. Okay.
I'm just trying it from my computer again, but some issue with the Google Meet.
I see. You know, 3 days ago there was a national Zoom outage.
Yeah, there is some issue. I think. Let me rectify it. I'll get back. I'm here only.
Sure. No problem. Take your time. Dr. Hussain, how are you?
Hi, good morning. Srinivas.
Good morning. Nice to see you.
Good morning. Do you remember me?
Yeah,
Do you remember
somehow
me?
you don't age. Looks like. Yeah, certainly. I mean, you taught us a lot. I mean, you did teach us a lot of orthodontics.
Thank you. Thank you. Nice to see you.
In fact, I do remember a couple of your paintings too.
Oh, thank you. Yes.
You still get up to? Do you get some time to do it again?
Yes, I kept some time for painting. Yeah, also. There's something I didn't give up.
Nice.
Even yesterday,
I didn't get that.
we had
Sorry.
2 days yesterday.
Oh, I see. I see. Age doesn't seem to have caught up with you. No change.
Really? Thank you. I'm a grandfather now.
Wow.
I am a grandfather.
You kept more hair than me.
Yeah, luckily only that is remaining. That's not gone. So far.
Nice.
Now if it goes on, it doesn't matter. So
Congratulations, on
Thank
the
you.
family. That's nice.
Thank you.
Amit, were you able to log in?
Yes, I logged in from my computer just now.
Okay.
Can you hear me, Srini?
Yeah, I can hear you well. You can hear me, right? Then I am not using
yes. We have 87 participants as of now.
Okay.
It's increasing 91, yeah.
Whenever you want me to share, let me know.
So is Dr. Jagdish here? Good morning, sir.
Dr. Hussain, the practice is,
Good morning, Amit.
Full-time in practice or you're teaching only?
Who you talking to? Srinivas?
Yeah. Dr. Hussain.
Yes. You're talking to me about practice.
Yeah.
I'm maintaining a small practice in the evenings after the college hours. So it is not a full time, but very small, yeah, orthodontics.
Hi, Dr. Jagdish.
Good morning, Amit.
Morning, sir. Morning. I hope all is
How are
well.
you?
Yeah, I'm good.
Yeah, all is well. All is well.
Great. So we'll be starting when, sir? Like in another 5-10
Yeah,
minutes?
in another 1 minute we will be starting.
Okay, right.
Yeah. We have now more than 100 people already joined.
Yes.
We will start with the webinar now. Good morning to all. On behalf of the Department of Oral and Maxillofacial Surgery, Yenapaya Dental College, I, Dr. Joyce Sequeira, Professor and Head, welcome you all for this webinar on orbital trauma, oncology and reconstruction. I believe that the PG training in oral and maxillofacial surgery is incomplete if they don't gain skill, knowledge and confidence. So there are so many webinars arranged by various associations making use of this pandemic. We too thought of having one. I had met Dr. Srinivas during our national conference at Bangalore and discussed a case as well. Fortunately, he is Dr. Jagdish Chandra's friend, and we thought he would be an apt speaker for our webinar on orbital trauma. So I thank him wholeheartedly for agreeing for our request. I welcome you, Dr. Srinivas. I welcome Dr. Amit Dhawan, who is a renowned maxillofacial surgeon, professor in SGRD Dental College, Amritsar, who agreed to spare some time with us for moderating the session. Thanks, Dr. Amit. I thank Dr. Jagdish as he is the person behind arranging this webinar. Thank you, Jagdish. I thank our Honorable Chancellor, Mr. Y. Abdullah Kunni, Pro Vice Chancellor, Mr. Farad Enapaya, Dr. Gangadhar Somayaji, for all their support and guidance rendered. A special thanks to our Dean, Dr. Akhtar Hussain, for his encouragement and never-ending motivation in all our departmental activities. Thank you, sir. Well, success story begins only if the team is working together, for which I thank my entire department colleagues. There is a good response for faculty and by the faculty and from various dental colleges for this webinar. We have crossed more than 250 registrations already. I request everyone to attentively listen and make use of this webinar. Please clarify your queries at the end of this session. Now I request Dr. Akhtar Hussain, Dean, Yenapaya Dental College, to say a few words, followed by Dr. Jagdish will coordinate with this webinar session. Thank you, one and all. Jai Hind.
Hi.
Over
Dear
to
Dr.
you,
Srinivas, Dear Dr. Srinivas Chandra, the speaker today, Dr. Amit Dhawan, the moderator, Dr. Jagdish, the coordinator, Dr. Joyce, faculty members of the department, maxillofacial surgeons and other surgeon colleagues from other specialties. A very good morning to you all. And of course, my graduate students. You know, increasingly overlapping areas in various specialties calls for a teamwork for better understanding and coordination, especially in complex cases as in orbital trauma, oncology, and reconstruction. And I'm very happy that our department of oral maxillofacial surgery has taken up this task to conduct this interdisciplinary webinar, which I'm sure is going to be a very informative and a helpful one to all involved. I wish the webinar all success. Thank you.
Hello and good morning to all of you. Am I audible?
Yes, sir. You're audible.
It is with immense joy that I introduce Dr. Srinivas Ramachandra, who also happens to be my senior from my undergraduate days. Dr. Srinivas is an associate professor at the University of Nebraska Medical Center, Oral Maxillofacial Head and Neck Surgery and Veterans Affairs Medical Center. He was the head and neck surgeon at the Fred and Pamela Buffett Cancer Center with expertise in craniofacial reconstruction, trauma, head and neck, oncology, and microvascular reconstruction. He was formerly at the University of Washington, Seattle, and attending surgeon at Harborview Medical Center, University of Washington Medical Center, and Seattle Cancer Care Alliance. He is AOCMF and Advanced Trauma Life Support faculty as well. Dr. Chandra completed head and neck oncology surgery and microvascular fellowship at the University of Florida College of Medicine in Jacksonville. Dr. Chandra holds a postdoctorate diploma from the Royal College of Surgeons of England with extensive training received in various maxillofacial units in US, England, and India. He holds a medical degree from St. George's University School of Medicine and a dental degree from Cots Manipal University. He has held teaching positions across 3 continents. He has an interest and practice niche in vascular lesion management, reconstruction as a tertiary referral. His practice involves high volume, full spectrum head and neck oncology and reconstruction. He has certification of qualification from American and international boards in head and neck oncology and microvascular reconstruction. He has presented in multiple international conferences and operated in maxillofacial surgical units and facial cleft surgery centers. He has contributed multiple chapters to books, published articles in journals, and mentored many peers and students through residency. He is also a member of many professional associations. Today, Dr. Srinivas will enlighten us about the various aspects of the orbit and its reconstruction, and I am sure all of us will get benefited by his presentation. We have Dr. Amit Dhawan as today's webinar moderator, who is a well-known figure in this part of the world. It is an honor to introduce him before you. Amit completed MDS from GDC Bengaluru and later continued to do his fellowship in head and neck cancer surgery from Kidwai Cancer Institute in 2008. He was awarded rotatory FHNO fellowship from Tata Memorial Hospital, Mumbai, and AOCMF fellowship from Hannover Medical School, Germany. He was honored with Jinwala Trophy for Best Paper Presentation in 2011. Another feather in his cap of accomplishments is that he has and also International Board Certified Oral Cancer and Reconstructive Surgeon in 2018. He is the editor-elect of our official journal and currently working as professor and operating maxillofacial and oral cancer surgeon in SGRD Dental Institute, Amritsar. He is a member of AOMSI, AOCMF, IAOMS, FHNO, and has more than 35 publications in national and international journals. He is the most seeked speaker by various forums. Thank you, Dr. Amit, for accepting our invitation to moderate this webinar. And now I request to take over the proceedings.
Thank you so much, Dr. Jagdish. I humbly thank Dr. Akhtar Hussain as well as Dr. Joycey for introducing me. And without wasting time, it's a good opportunity for me as well to learn from my very good friend Srini, because we have been in so many meetings. We talk a lot on phone as well, and we are working on so many publications also together, and hopefully we'll come up with some in a near future. Without wasting time, Srini, welcome. Can you share your screen and unmute yourself?
Doing that. Thank you. Do you see me?
Yes.
Okay, I'm going to go on the.
Yeah, you can go to present now and you can share your screen, I think.
Amit,
so this is
request to all the delegates or viewers to switch off their camera and mic.
Yes. So it is better for all the delegates and attendees to kindly switch off, kindly mute themselves and switch off their videos, because it will give you uninterrupted transmission of the webinar. And whatever questions during the webinar you think that you want to ask from Dr. Srini, Srinivas, you can message in the chat box, and I will address your questions whenever and when we have a break in between. Most probably we will have a little bit of breaks in between so that your questions should be answered. So if you can drop in your questions in the chat box, I will make a note of it, and your questions will be addressed. Thank you.
Dr. Dhawan, thank you very much. And my honor that when you are moderating this, as you said, Dr. Joyce, Dr. Jagdish, and Dr. Akhtar Hussain, I'm not a stranger to you, and thank you for having me. I really appreciate it. So if I could start on the orbit, and with due thanks to each one of you and the Anapoya Dental School and all the postgraduates and your trainees. Please challenge me or ask me questions, or if I'm not clear in any particular, on any of these particular cases which I'm doing, let me know. So this is a challenge for you guys, each one of you out there. I want you to look at these three pictures and close your eyes, just like two of the patients there are closing their eyes. Tell me which orbit or which eye that the globe has a defect.
Srini, I think have you shared your presentation, or it's
yeah.
It
you
is
don't
not,
see my slides?
I don't see your slides.
You don't? Okay.
Dr. Jagdish, can you see the slides? Because I am not seeing the slides.
No, we are not able to see.
Yeah, I think it is.
Okay, now
it is not shared. No.
Can you see him now? Okay, let me go back and check.
Srini, you have to share your screen.
Yeah, present now.
Yeah, there is something called as present now.
Yeah, I went to present now, and
that share screen, it has come.
My entire screen.
Yeah.
Allow. And do you see that now? Do you see my screen?
Yeah, now it is.
Yeah, now it is visible, Srini.
Okay, I'm going back to presenter mode. Let me know if you can see. And do you see the slide now?
Yes, if you can do it in the presentation mode. This is a presenter's screen, I think.
Okay.
Yeah.
Is it
yeah, this will be
now?
fine. Yeah. Yes. Yes.
Okay.
Yes.
Perfect. So rerun this again. So each one of the participants, if you can just out of the two patients have presented, two frontal views and one submental vertex view. If you could guess who's got vision, who's got a defect, and what are the defects. So as we go through the presentation, you will realize what are the challenges in reconstruction of an orbit. And I really want you to think about 7, the number 7. So orbit is so unique. We are across 7 seas, and it has got 7 bones and 8 surfaces. Of course, the front opening onto the eyelids, which is the base of the pyramid, and it's got 7 muscles. So think about 7, and I'll keep alluding to everything in 7s. So these are the objectives of the lecture, and we will address each and every one of these from the anatomical considerations, the concepts about surgical management, the adjuncts, the trauma, what type of trauma, the infection, neoplasia, the skull base axis, reconstruction, and complications and pitfalls. All of this I will address in each case representation of mine. I've chosen cases particular to each one of these, and we'll go through them. may not be in sequence, it could be in concepts. So if you could allow me to entertain you with some amount of anatomy. So just like the nasal cavity, the oral cavity, the orbit is a cavity, but orbit presents the neurocranium. That is, orbit has got a sensory organ. Part of it is covered by the dura mater, that is the optic nerve and the adjacent vasculature, and it presents itself in two pyramids sitting on the side. So the base of the pyramid is what your eyelid is, but the pyramids are angulated, angulated away for the stereoscopic vision we have. If you could imagine a chameleon or a rhinoceros, they have a completely side set view, whereas ours is about 45 degrees from the apex across to the straight line vision. So looking at the orbit as such, it has got a rim, it's got a roof, it's got a base, it's got a side. And as you see, we will explore each and every bone of this orbit cavity, which is made about 7 bones, as I said. And on the screen on the right side shows the vasculature at the corner of the eye. They call the angular veins. These angular veins are very important. The angular veins are coming as a direct offshoot from the internal carotid artery through the orbit, coming out from there. They flow onto the forehead, they flow onto the dorsum of the nose, medial part of the eyelid. They form a full web on the upper and the lower eyelid. And we will use each one of these vein to do something to treat a patient and apply the axis osteotomy in the skull base patients, which I'll show you. So the next important concept which you want to see is this particular bone. Except this bone, all the other bones are in pairs. I told you 7 bones, all of them are pairs, except this midline bone called the ethmoid. In the midline, what you see is the crista galli, which is going onto the surface of the brain. And then there is this air cells or the air pockets you see. These are the ethmoidal air cells. So the ethmoidal bone on either side, the right and the left, you see the flat surface is quadrangular in shape. This quadrangular shape is what forms the medial side of the orbit. So the medial wall of the orbit, majority of it, is formed by this particular bone. In the front is the lacrimal bone, and the back is the sphenoid bone. But ethmoid, once it breaks, is very difficult to reconstruct. So that's the reason the entire concept of orbit fracture reduction is known as orbit reconstruction rather than orbit fracture reduction. So these ethmoidal air cells are unique. The amount of volume in each person is a little different. So they create a little bit of a challenge of a 3-dimensional flowing wave medial wall of the orbit. So when we look at this ethmoid on the right cartoon, even though it appears straight as the Google would pick you up as a cartoon, it is not straight. It is rather curvy with the posterior medial bulge and number of air cells as you see. And the small lacrimal bone, do you see my cursor, Amit, Dr. Dhawan?
Yes, I can see Srini. It's nice.
The cursor, yeah.
Yes.
So the cursor is showing you the lacrimal bone in the front, which has got the canal in the front, and then there is the sphenoid bone at the back. This is the anterior clinoid process. So if you represent the same thing in the cadaveric representation on the left side, this is the dura mater, and once you go under that, the middle part of it is the olfactory bulb. These are the ethmoidal air cells. So there is the optic nerve, and there is the internal carotid artery through which one of the branches coming on. These are the nerves, and this is the entire orbital cavity here, enclosed inside the dura and the periosteum. So this is the frontal bone looking from the bottom. This is the front where the nose is on the top. and this is the roof of the eye. So the ethmoidal bone articulates into the middle of this, and these are the air cells, which are the continuation. So the medial wall meets the roof at a fairly good angle, whereas the floor is a different story altogether. So the cribriform is the midline, what you see in the middle, and then there is the cristogalli, and then there is the planum posteriorly. So the nasolacrimal orbital fractures happen around this region. So the naso-orbito-ethmoidal fractures. And then if you translate that to the picture on the right, which is a dissection model of a skull, it is fairly important to see the midline, the pneumatization or the air pockets of each ethmoidal air cells. And just adjacent to that is the optic nerve in the optic foramen, on top of which run the nerves. This is the superior rectus sheath and the Whitnell's fascia, along with the levator palpebral superioris. And then you see the lacrimal gland on the right side, and the rectus, the lateral rectus and the medial rectus. The medial rectus here, this is the oblique muscle, so the superior oblique going into the trochlea. But watch the carotid here. The carotid has one or two branches, which gives the ophthalmic artery, and the ophthalmic artery is what gives the retinal vein. So any compression from the top causes occlusion of this. So we will keep visiting this back and forth. This is where the cavernous sinus is. So any infection coming from any of these blood vessels which come onto the forehead, or to the sinus mucosa, or to the nose dorsum, any infection coming from there comes through here, through here, and into the cavernous sinus. I mean, it could be the veins or the artery. So now we put the frontal bone, and we have the sphenoid like a butterfly sitting here. This is the lesser wing of the sphenoid, this is the greater wing of the sphenoid, and this is where the ethmoid bone would sit back in here. There's another, that is the palatine bone. The palatine bone is missing in between the maxilla and the sphenoid. So if you look at this cartoon again, this is the sphenoid at the clivus, and this is the maxilla, and this is the zygoma, and this is the ethmoidal bone, and this is the lacrimal bone. So this is your maxilla, separated, each maxillary process forms the front rim, forms the zygoma, and forms the zygoma attaches to the greater wing of the sphenoid. The sphenoid is the single bone where between these two wings is the superior orbital fissure, inferior orbital fissure, and the optic foramen. And if you see the floor, major floor is formed by the maxillary bone. And there's a part of the bone which is also formed by the palatine bone. This is the palatine bone, and this is the horizontal part of the palatine bone, which forms the posterior part of the hard palate. This is the horizontal part, and there is the vertical part. The vertical part has got two projections, the posterior projection and the anterior projection. If you watch it very closely, the posterior part goes to the sphenoid and forms the pterygopalatine fissure there, whereas the anterior part has got a small air cell, and this is the floor which forms this surface actually forms the small contribution to the floor of the orbit, very posterior, just adjacent to the superior ophthalmic fissure and just anterior to the optic foramen. So it is the smallest representation of the floor, and that is formed by the palatine bone. So that's the palatine bone. And the last but not the least, but this is the smallest bone, which is the lacrimal bone. So the lacrimal bone, this part of the superior surface goes up to the frontal bone, and that's where the tear canal starts. That is the beginning of where the orbicularis oculi attaches to that to form the Horner's muscle to pump the tear duct going from there, from the frontal bone all the way into the nasal concha. So part of it attaches to the maxilla in the front, part of it attaches to the posterior. You would think this is just an anatomical representation of the skull base, but look, there is a clinical representation of a patient who has had a firearm injury in self-inflicted gunfire to the chin, where the mandible is missing, the maxilla is missing, the major part of the orbital anterior floors are missing, the nasal bones are missing. So that would be the representation of approximately this one. So there is a clear-cut indication for knowing each part of the anatomy. So turning on to the epidemiology after this, the epidemiology tells you, at least in the US, there is 3 to 5% of children have some amount of orbital and ocular trauma. And 1 in 5 adults have some point in their life have had some sort of trauma in the orbital and the ocular region. So each region has its own. So each occupation, each age group has its own epidemiology of different types of injury. I mean, you could be a welder, you could be a dental surgeon, you could be an orthodontist, you're clipping wires. I mean, if Dr. Akhtar does not wear eye protection, maybe the wire would hit the eye corneal surface and may hurt. So, I mean, you would want to wear your eye protection all the time. And then each subset of the orbital is again different. Small kids have dogs. I mean, the dogs can pull on the lower eyelids and that can hurt eyelids as well as facial injuries. And even domestic violence with women have isolated wall fractures. And it is very well documented that's a subset of injuries which is seen in domestic violence. So the right side tells you approximate percentages of fracture sites. And you would notice adding up all these numbers, it doesn't add up to 100. It's a little more than 100. So the majority of the orbital fractures happen on the floor. That's the maxillary component. So that's the thinnest part. And the least amount happens on the roof, which is the brain. So it is an evolutionary protection mechanism that the roof or the brain is protected. And when you squeeze or any injury, either it could be a compressive force or it could be a displacing force to the orbit. The entire globe can deform and the globe can decompress on the thinnest floor or the medial wall, that is the ethmoid bone. But between the percentages, you will notice there is no single component which would happen all the time. There would be more than one wall which can get fractured. So the rim is fairly robust. So that's where we attach most of our hardware to treat these orbital floor fractures. And you see the entire contents of the orbit on the left side. So we'll talk about each one of them as we go by. And one last thing, we need to understand a concept about cone, extracone, intracone. So if you remove the bone of the orbit, the entire socket or the cavity, there is the periosteum which runs along with that. So anything inside is intraconal. Anything out of that particular cone is extraconal. So you'll notice that the optic nerve is running here between the clivus and in the foramen itself. And there's a orbital superior ophthalmic artery which runs through on the top and enters it at some point to become the central retinal artery. And then you see the trigeminal branches which are entering too from the lateral surface. So the ethmoidal air cells in the midline are here. So if you understand the concept about cone. Now we'll come back and understand a little more about the apex of the orbit. So apex of the orbit has got a tendon here, a circular tendon called the tendon of Zinn or the annulus of Zinn, annulus meaning circle. So here is the optic foramen. This is a superior orbital fissure. So through the optic foramen comes the optic nerve and the ophthalmic artery. And from the central part of the superior ophthalmic fissure is the third and the sixth nerve along with the nasociliary. And there is the fourth nerve, and that is the abducent. And then there is the lacrimal and the frontal branches of the trigeminal. So the oculomotor is here, which supplies most of the muscles of the extraocular muscles. So injuries, again, just to elaborate on the type of injuries after epidemiology, could be just conjunctival injuries. So you scratch your conjunctiva either, or you really injure it either by a scratch or by some foreign body, or contact lens wearers have a high instance of fungal infections, pseudomonal infections, and infections. And burns can be thermal burns, could be acid, alkali, the worst part of it, the alkali. And then the penetrating ocular injuries. Penetrating can be complete penetration or just perforations, superficial through the sclera. And then a impact can cause just the lens to displace itself or the retinal component to displace. Usually you'll get floaters, and after a couple of floaters, you will have sudden loss of vision or like a screen going down. So that is the common thing which people would say. And there are inflammations and infections. Even odontogenic infections or tooth-related infections are fairly common, which can cause significant amount of infections. And just to complete the anatomical part, there is the lacrimal gland and the fat pad. In any injury, you get this displacement of the globe of some sort. Proptosis, it is called, or exophthalmosis. Or if it sinks inside, inophthalmos, or hypoglobus in the vertical position. And the middle part is representing the orbicularis oculi. Orbicularis oculi has got multiple leaves of muscles. The central leaf around this pooling of the sac, that is the tear sac, lacrimal sac, is Horner's muscle, and in the middle it's the tarsal part of it. And here on the right side, the CT scan on an axial region, you'll notice there is a fracture of the medial surface, and that is impinging on the optic nerve here, when the nasal bones as well as the medial part of the wall is broken. So that is causing the representation on the cartoon. This is a real patient, which I got a representation of a 3D model, so that the lawyers could understand what the patient has gone through. So one other reference to the orbit anatomy, and we'll be done with anatomy fairly soon. And this is again a rule of sevens. So how far is your optic nerve from the rim of the globe? So it is all in sevens again. From the rim, it's 21 millimeters, that is 3 times 7, is the anterior ethmoidal artery. And about 14 millimeters from there is the posterior ethmoidal artery. And then 7 millimeters from there is the optic nerve. The reason I say such a thing is between your exploration, so you can go as far as about 4 centimeters inside. And you will encounter these bleeds commonly if you do not care for them. They're also representation of the brain, and that is coming from the internal carotid. So, you may not be able to control the bleed if you do not clip it adequately. So you want to put a clip on this or cauterize it as you go dissecting deep inside. So one additional terminology. So we have done with anatomy so far. So a little bit of terminology. There are 3 terminologies when you deal with removing an eye. So eye, as you see on the top, you leave the sclera and you remove just the contents inside the evisceration. So that is the bottom one. You take out the lens and the clear part of it, the vitreous and everything, you just scoop it out. So these are usually done by the ophthalmologist. This is because of a penetrating injury where it is very common for a sharp injurious object to go inside and cause that. But that is the least thing. You can go home the same day and you can put a prosthesis, you can rebuild it, reconstruct it very well, except the terrible result of blindness. Then there is the enucleation of it. Enucleation is you remove the eye with the sclera, but you leave all the muscles behind. You cut it at the, as you see, the stump of the optic nerve. Either I can do it or the ophthalmologist will come and do it. This is when, again, pain, infection, it could be because of trauma or whatever reason, you remove it, and again, you can put a prosthesis inside, and I'll show you the outcomes of what we've done, and the prosthetic does very well. Then there is the last complicated term called exenteration. Exenteration is you remove the eye, the bone, the nerve, the muscles, the fat, even the eyelid. You can remove everything. This is because of tumors usually, spread of tumors, and I'll show you a few cases for them. And just finishing one component of the entire orbit is you can have infections from the orbit. So in this case, on the left side, it could be an odontogenic infection. You see that huge on the CT scan, the axial CT scan with contrast on it. You see the blood vessels which are lighting up very well. And the left, this globe on the right globe, it's a little different compared to the side. There is the lens here, and there is the perfect, shape of the anterior chamber and the posterior chamber, optic nerve, and the muscles. Whereas if you see here, there is thickening of the optic nerve and the sheath of it, and there is a lot of fat stranding. This is called fat stranding because of contrast, and there is amount of inflammation and infection and edema, and that propagates to the cavernous sinus and the cavernous sinus lights up fairly significant amount of it. So that's caused a little amount of rotation of the eye. That's the reason it appears as though it's almost circumferential. That should not be the normal appearance. And or you can get what is on the right side known as the preseptal cellulitis. I've seen this. This is one of my patients where the infection happens either because of skin infection, staphylococcus infection, or it could be spread from the adjacent region. And the skin dies because the blood supply to the skin comes through small blood vessels perforating through the orbicularis oculi. And so you put a drain in and you drain this on antibiotic treatment. This has to be treated with significant amount of IV antibiotics for a long time. And both of these patients can cause significant sepsis. Cavernous sinus thrombosis is fairly a fatal condition occasionally. And this is the concept about treatment, a flow diagram about eye injuries. If you have a closed globe, contusion only, that is compressive injury, the superficial foreign body or partial laceration, you can do fairly okay. And if there is laceration, the laceration of the eye as such through the sclera and the cornea, it can be just perforating. If it is perforating, that means the vitreous is going to come out, or it could be penetrating and maybe not much loss. You can put more fluid into the vitreous and close it, or some rest that can happen, or it can have a rupture. I'll show you a few cases of rupture. So again, signs and symptoms for everything, trauma and tumors and infection. I'll tell you, pain is possible, numbness is possible, the orbit protruding out or the proptosis is possible, and periorbital mass, the lacrimal gland tumors, or if something else is growing adjacent to the area, that's a periorbital mass. Epiphora is tearing. The tear should never come out other than the emotional part of it. The tear should drain into the nose. Epiphora, that means the tear ducts are blocked either because of tumor, trauma, or scarring. And then change in visual acuity. Visual acuity is the most significant function of a globe and the eye. So any change in visual acuity, you need to pay attention. And double vision, diplopia. And then rhinorrhea is runny nose. It could be because of tumor, blockage, again, infection, as well as trauma, obstruction, and nasal obstruction. So this on the left side is a standard web picture where the patient is trying to look up at the bottom. The right eye is looking up, the left eye is stuck. This is because of the fracture here on the coronal section. Coronal section shows there is a trapdoor defect on the floor of the orbit with some amount of adnexa or the fat or getting caught. This muscle should be almost spindle shaped, almost, but it is being pulled down with the trapdoor of the fracture here. And then on the right side, you see a patient whom, just for the patient privacy, I've been trying to get a closer. So he looks up and down, no restriction. You see a subconjunctival hemorrhage. Medial and lateral function is fairly good. Oblique function is fairly good. So even if there is an injury and edema, you can watch this patient. Those is the examination, which is very important for external ocular, external muscular movements. So imaging, what do? You can do plain films, CT scans, MRIs, ultrasound, cone beam. Cone beam is the same CT scan with low radiation. So plain film examination, this is on the top, you see, this is a frontal view. You can do a lateral view, but this view is called, we don't do this anymore, but it's wonderful. I mean, it does work. 70 to 80% sensitivity of picking up the rim fractures, floor fractures. It's there some for the postgraduates. They're called as McGregor-Campbell curvilinear lines. The curvilinear lines or the superior orbital, superior rim, inferior rim. Then there is one running across the maxilla. So these one running across the nasal contour. So McGregor-Campbell lines, they were called. And then the Cardwell appearance or the Waters view, either of them would give you an anterior wall of the representation if there is a fracture there. Fairly good. And I mean, Dr. Dhawan can tell, Dr. Jagdish Chandra, Dr. Joyce can tell, I mean, more about, which would be indicated in each one of them. So the CT scan here is fairly good. You can do it in acute bleed immediately. And you could do it in very thin sections of 1 millimeters each. And then you can pick up a lot of pathology. You can have 3D formatting and oblique slices if you talk to the radiologist and you format it yourself. And you can do it on a protocol where you can use it for navigation and a lot of technology review of this, which we will go through. So you see the central and the muscles there, and then the adnexus sticking out of this orbital for fracture. The MRI is good. We do an MRI for most patients if you need to look at the fat, the muscle, if there is invasion of the tumor to the dura through the cribriform plate, and it gives you a beautiful T12, T2 weighted images can give you a beautiful appreciation whether it is inflammation, if it is mucus, inspissated mucus in the sinus, or the muscle itself being trapped or ischemic and other things. So, but you need thin slices for it. So you need to be careful what you ask for. An orbital sequence in some institutions, you can get fairly good thin millimeter sections. If you miss that, you may miss a major finding like a superior orbital fissure by itself. So you want to have thin sections. And as you see, you want to position the patient in such a fashion that there is no tilt of the head, so that you get a good representation of comparison between the right to the left. And you can use that if you have to mirror image it, or if you want to compare one side to the other. So this is a patient with a medial wall fracture on the right side on an axial view of a CT scan. You see this medial wall protruding and causing deformation of this medial rectus. So the lens is intact, the globe as such is intact. You see some amount of air entrapment. It could be edema, or it could be just subcutaneous emphysema. And then you see the right side optic nerve. I couldn't say much unless you look at multiple sequences, how much of it is being stretched or stranded compared to the left side. So you don't see much of the floor other than the lateral wall and the medial wall here, and the significant posterior positioning of the naso-orbito-ethmoidal complex. So then the most important thing you would want to know for anybody who's dealing with orbital injuries is a retrobulbar hemorrhage. On the left eye here you see there is proptosis, that is exophthalmosis, or eye protruding outside. The lens is intact, the globe is intact. The nerve, I wouldn't make much comment, just looking at one sequence. There is a little bit of retrobulbar hemorrhage here. This retrobulbar hemorrhage, meaning I told you about the anterior ethmoidal artery which comes here and the posterior ethmoidal artery which comes here. Anterior from the rim is 21, 21 plus 14. So anything anterior to this 14 millimeters is the bulbar part, bulbar of the eye. This is the retrobulbar between that 21 and the 14 millimeters additional. So that's where the retrobulbar hemorrhage happens. And if it goes further down between that 14 to the 7, that becomes the apex, optic nerve apex. Apex syndrome, you will lose vision immediately. Retrobulbar, you don't have to lose vision immediately, but you will have significant amount of pain. You will have significant amount of difficulty moving the eye. You will have significant amount of proptosis and some amount of paresthesia because of compression of the sensory as well as the um, sympathetic nerves, causing even some amount of pupillary lethargy on reflexes testing. So what you want to do for a retrobulbar hemorrhage? Ultimately, you want to see if it is progressing or if it is a small thing. If it is a small thing, I've followed it for some time. If it happens sometimes after you've done an extensive orbital exploration, then you can wait and watch. Or if it is progressing, you don't want to apply any direct pressure. You give some diuretic called mannitol, and you give some CSF suppressing agent to acetazolamide. You give steroids to avoid swelling. I mean, you want to get a CT scan fairly quick. And if it is a kid, you can get an ultrasound and see if the hemorrhage is progressing or not. So the standard treatment done in majority of the world, of course, some institutionally it's different, is lateral canthotomy, at least University of Florida. I mean, most of our younger trainees would know how to do it. You can do it under local anesthesia in the emergency room or in the accident and emergency. All you have to do is inject a little bit of local anesthesia in the lateral side, and posterior and superior direction, you cut the lateral canthus attachment to the lateral tubercle. So that releases it, and you can go inside and release. There are people who do it from inferior as well as superior side and put a drain in. If you have ultrasound guided, you can see the ultrasound, where the hematoma is, and drain it. But you want to make sure that the patient is sitting up. I mean, the bladder is not full. That increases, meaning, anxiety, pain, nausea. If you cough, that can increase it. So if the patient is on aspirin or anticoagulant, you want to make sure that you stop it. But the worst outcome is in this one. If you see the bottom picture on the CT scan here, the entire optic nerve itself is avulsed, and you see this stump on the bottom. Unlike the one on the right side, the optic nerve is the globe is rotated and there is avulsion. This is from the radiology lectures available, and then I don't have a patient whose optic nerve avulsed just like this much. Whereas this one's, there is a little bit of proptosis, little bit of edema, but this is my patient which I've rendered into a 3D saying some amount of fat herniation. So what do we do with optic nerve avulsion or a hematoma? So we want to make sure that it is not anything else, optic orbital compartment syndrome, where it is compression, because until you get a CT, you do not know. But the signs and symptoms are the same: pain, either loss of vision or double vision, and proptosis, the globe, meaning protruding outwards. Subconjunctival hemorrhage may be there, may not be there. The eye movements may be limited, and certainly loss of pupillary reflexes. But any loss of central retinal ischemia would lead for more than an hour, even 60 to 90 minutes, can leave permanent loss. And one important thing in evaluation of retrobulbar hematoma or any mass or edema is the intraocular pressure. You use what is called as a tonometer, which is a pressure gauging machine. You can carry it in your hand. A pen tonometer or a split lamp exam can give you a tonometry exam too. So rough guide, less than 15-20. When you can go up to 40, you can be fine, but it should completely go down after some time. But repeated exam, visual acuity is the key in orbital examination. So that is almost the end of examination and the injury part of it. If there are any questions, we can chat about it, or you can look at this particular orbital sagittal sections where the patient has been treated and the patient has significant edema. I mean, of course, where the position of the posterior ledge is, but what I'm trying to represent it is you can get edema even in a posterior, post operative area. So you want to observe the patient even post-operatively with hourly visual checks, or you can check it in a graded fashion. 15 minutes if you're worried for the first 2 hours, after that hourly, after that 4 hourly, or hourly for the first 4 hours, and then maybe every 4 hours, I mean, based on the progression. So what does the literature say of when to treat the patient? In the next few slides, we'll talk about treatment. And this is a publication from the BJMS for 2012 of 48 patients in the decision making. So they say conservative treatment up, on the right side, conservative treatment advised if the fracture is less than 3 cc, as long as enophthalmos is less than 2 millimeters. 2 millimeters enophthalmos is almost nothing in an edematous patient. Only correlation study between fracture size and enophthalmos. You can follow up as long as 3 months. So the most important statement is initial diplopia after injury may not be an indication for immediate intervention. So you want to wait and watch from the swelling to go down unless there is deterioration of vision, double vision, getting worse of everything. So then you can intervene, but wait until the actual diplopia resolves with the edema. Saying that, there are a few other things. I mean, there are 3 publications which are represented in bullet points here. The first one says enophthalmos proportional to fracture area and volume of herniated tissue. Enophthalmos is expected if it is almost 2 centimeters, or if there is a volume loss about 0.9 to 1 milliliter. Anything more than that, it would give you enophthalmos. So enophthalmos is a good indication for correcting any orbital floor defect. And we said we would talk about a defect, not a fracture. So that's the concept. We talk about fracture reconstruction rather than fracture reduction. So that is the concept again in orbital treatment. So another study in Ophthalmology Journal from earlier sometime 1983 caused orbital floor fracture of more than 50% and transposition of more than 3 to 5 millimeters. That is dystopia, that is hypoglobus, enophthalmos, anything. That is indication for treatment. If you talk to 10 people, 8 out of the 10 may agree that 50% or more floor injury or wall injury, they would want to intervene. And there is another plastic journal thing which says 2.5 centimeters to 3 centimeters square, which agrees with the first paper. So that's about the literature. And I introduced a few concepts. This is the concept I want you to all go home with. That is, vision is bilateral. This is the only thing which is the key ultimately. You want a good functional vision, as well as aesthetics. The aesthetics is the volume. Entire orbit reconstruction and the fracture reduction or reconstruction of the defect is to create the normal volume of the orbit. Orbit has about 30 cc. So you create that back. Different ethnic people, Asians, blacks, Europeans, I mean, each race has a different amount of orbit, or ethnicity has a different amount of volume. The depth of the globes are different. So there is some amount of difference. And then orbit management is fairly key in panfacial fracture reduction. So whenever you reduce a fracture like the one which I've represented, this was about 20 years ago when, you do the fracture and you see this zygomaticus pinoid, there is huge diastema here, and there is significant amount of volume increase. This is not a good reduction. Even though if you used multiple set of plates, the volume is not recreated. The NOE fractures are not reduced, and this will not give a good outcome for orbital function or orbital aesthetics. And then there are 2 times when you can correct. You can do it in an acute setting, and majority of the patients I see are corrective patients where you correct it from multiple stage surgeries or some complication at some reason. Then the soft tissues have to be cared for in an orbit reconstruction. And then you need adjunct for examination and surgery. Adjuncts are the things which we'll talk about. So In a pediatric patient, there is some emergency in treating some patients. So if you notice the one on the left, by 5 years of age, most of the orbital volume and the orbit development is almost done, except the mid-phase projection, of course, and other things are still developing, but majority of the orbit as such is done. But if there is entrapment or a green stick fracture and there is a muscle which is entrapped, the ischemia of those muscles and scarring, called as Volkmann contractures, Volkman, Volkmann contractures, this can cause a significant amount of change or diplopia for immediately. And we'll see a syndrome which is associated with that green stick called the white globe syndrome. Here, the trapdoor is fairly open. You see the inferior rectus there and into the sinus there. And whereas in an adult, it's a little different, meaning you can take some time and the contractures of the rectus muscles take some time, ischemic changes of the muscle. In this case, it is a superior roof and the lateral compressive displacement, which is causing reduction in the globe in a coronal section. So this is the white globe syndrome, which is fairly important. You see the eye here, it's white. There is no conjunctival injection or hyperemia or redness. So that's the reason it's called a white globe syndrome. And every time the kid would look up, the blood heart rate falls, patient becomes significantly nauseatic, and then there is significant amount of pain sometimes. And you can literally see the kid lying down, trying to look up, the monitor, the heart rate immediately drops. So this is called as a white globe syndrome. We took care of this patient a couple of years ago with a classic trapdoor here where there is the muscle which is entrapped and stretched. The representation on the screen may not be very, very dramatic, but it is a very dramatic appearance. You want to take this patient to the operating room as an emergency. I'm showing you a sagittal view. Posteriorly, it was a bigger defect. And if you notice, the right eye, which is my hands, which is moving the globe, which I'm not using at the limbus, it does move. Whereas the left, wait and watch, is fairly entrapped with a significant amount of traction. So that is an entrapped muscle. So the kid cannot look up. So it is the attempt to look up causes bradycardia and nausea. So that is the white glove syndrome. And so anyway, the teardrop in an adult, again, the representation that's a classic floor fracture, which is a blowout fracture. It could be a small thing. Once you start messing around the floor, you will lose that component and you may need to put a big plate there for the entire defect. This is a different plate. So if you notice, that's the reason it is called fracture, and it's not fracture reduction, it is defect reconstruction orbit in an orbit. So that's the concept. So if it was just this much, I corrected this floor with an endoscope. You can go through the mouth, through the cardwell look approach in the canine fossa, put a small endoscope, and you can push the orbital contents back, and you can use this like a endoscopic treatment, and it should be small isolated floor defects. This is a publication by my mentor, Dr. Rui Fernandez from University of Florida, about the outcomes of the 10 patients which were isolated orbital floor fractures with implant placement. Fairly successful done, but it has to be specifically just the floor. And another concept is when to intervene. There is a concept called hyphema. If you look at the right eye, there is a stranding of blood in the anterior chamber, and this is actual blood which sits there. So it can sit, this is a dilated pupil exam on both the eyes. The ophthalmologist is seen, the pupils are equal, but they're dilated after the exam. And you notice that there is stranding of some amount of blood. If the blood keeps covering the entire transparent corneal surface, if you mess with that eye, compress, manipulate, you can increase more bleed. And then that can be a devastating thing because that can stain your entire transparent on here, and then the vision is impacted. So this is the eye, this is a sports player. She got elbowed, as she was playing volleyball, and you notice that there is some amount of anaphthalmos, and then there is amount of edema, and there is hyphema. But we did wait and watch; it did not increase, so we went ahead and corrected this patient. I did it myself with minimal manipulation. So, but you want to make sure that you got a good preoperative CT. Make sure that what your manipulation, what your exact defect size, and then this is an intraoperative CT where immediately as soon as you're done with it in the operating room, you can obtain a CT. There is advantages, disadvantages to this that you can immediately see, you can correct it, because she was a sports woman. I didn't want to I wanted to make sure that there is no profile projection, or if she could get back to in her season of sport playing immediately. So this is just a splint, nasal splint, to make sure that there is no impact. This is our donut intraoperative CT scan. This is the patient lying down. We cover the patient with on the sterile, we can cover with another plastic sheath, and then this goes around, and this gantry runs around, and this gives you an intraoperative CT scan. The disadvantages are you don't get very thin slices. You cannot play around with it too much. And then another concept is just the plain orbit by itself does not give you a total reconstruction. So you want to make sure, say in this globe, you see a right globe and the left globe, there is a huge discrepancy. This is because this comminuted zygoma beautifully adapted, but it is bowing too much. This is not a symmetric representation. We all want to make sure that your anterior-posterior projection of your zygoma is optimal. So the bending zygoma is an arch, but it is really not an arch. It is almost flat and straight. This is a fundamental important concept about zygomatic positioning, which gives you the entire projection of your lateral orbital rim. And this is a basic concept which you need to understand in volume creation back to normalcy. And there is a third concept. Orbit, you could do all the preoperative mirror imaging, everything you could do, but if you have a bilateral volume increase, you do not have a representation. So in these cases, you would want to be very, very thorough in making sure that you get your volume equal on both sides, and you want to make sure you check all your reductions properly. And another important concept in this high velocity steering wheel accident, where the patient was not wearing a seat belt, and as she was forced from the back collision of another car onto the back, she hit the steering wheel onto her face, and there is significant compression of the mid face. This mid face, the naso-orbito-ethmoidal region, needs to be reduced really, really well. And I have a few NOE here, and one of my friend, Dr. Kannan Balaraman, always talks about NOE fractures in the Indian meetings and the international meetings. He's got a wonderful series of patients. So this is for him actually. So the orbital volumes are very well restored because the NOE component is good, the zygomatic projection is good, and so the postoperative CT scan shows you, even though the defect of significant amount of comminution, there is the rim which is recreated. But there are other ones which are penetrating trauma, which is high-speed velocity train. So this was the patient which I took care of. This is a car chase where you run into a wooden fence, and the fence comes through the windshield, and it penetrates all the way into your brain. You see the brain here, and the entire orbital component subsite is comminuted. So this is almost a 4-wall defect. The roof is gone, completely collapsed. The floor is gone, the lateral wall is gone, medial wall is gone. You'll see a sagittal CT scan of this, almost the brain herniation as well as the floor. So this is a significant patient where you want to take care of it with your neurosurgeon. Once you expose everything, the neurosurgeon would help you do this dural repair on the right side, and you provide adequate retraction. Once he is done with the dural repair, then you start putting back all the walls together. This is a chance for you to get autologous bone. This is where, a great textbook training picture for calvarial bone graft. People say that you should take it from the non-dominant side, monocortical. You can take it as big as you want. I've taken multiple strips from the front to the from the back to the front, and you can use that with reduction. You see the superior wall has been reconstructed, and you see the defect on the cortex on the other side, contralateral side, and then you create a titanium mesh on the bottom, and the floor and the roof is created. But you want to stage this. You want to make sure that the dura is supported well, there is no CSF leak. You put a flap too, meaning I've raised a flap. If you notice, there is a flap here, a temporoparietal good flap, and you want to cover the entire defect well, along with the dural repair as well as the prosthesis. And you want to make sure that you re-image again. This is another patient where you want to evaluate. Even a small amount of zygomatic projection can give you a different volume. So you want to re-image, stage your reconstructions, and you want to re-evaluate each stage of them. So this was the outcome of this patient who went through the high-speed collision through and through all 4 defects, the roof on the sagittal, the floor, and then from whatever this was mess, we recreated it. So high velocity 4-wall injury. This is a intraoperative CT scan. Again, you see the pixelation is not great as like the preoperative one, but a decent reproduction of the volume as well as the symmetry. This is another low speed, low velocity crush injury, but of a chain, an iron chain, which punched the patient as he was, this is a stranded car which was being picked up, and the chain hit him. And this is significant amount of globe injury. So at this times, ophthalmologists certainly sometimes take a few days to see if the vision is intact, and then you do not intervene, give adequate time to swelling to go down. But at the same time, these fragments may start resorbing, or there would be fibrosing at this end. So this CT scan, I was a part of, you take this patient, even with significant edema, as you see in the middle, you take those big bone fragments, you can put it on the table, realign them as much as you can. At least there is a contralateral side to compare. But again, the key concept of getting the NOE component very good, adapted, and then you need to suspend the ligament back into the canthal suspension is very important. And then you can put spacers here. You see, use some spacers, you can come back and do stage reconstructions later. And then there are other ones which are like the, firecrackers, or every Diwali or the Independence Day, when you have firecrackers, that is the emergency rooms full of are full of patients who've had eye injury of some sort. This is a avulsion injury along with the bone being lost. And there is some amount of adnexial injury too. So this is a fibular-free flap in multiple stage reconstructions, making sure that the orbital adnexia is important. So in blast injuries like this, you want to make sure that the scarring is minimal, contraction is minimal. And of course, this patient had infection of the implant which was replaced. So you want to make sure that the implant is not getting infected if it is exposed, antibiotic treatment, or make sure that you take adequate care to do all this. So that is an infection. And then you get this no bony injury, but you get this eyelid laceration in this kid. Dogs are the commonest thing. You run behind your kids to make sure that your pets or any of this do not avulse the eyelid here. So this is a full bilamellar anterior lamella, that is anterior to the septum, posterior, complete full thickness avulsion of the lower eyelid. This is the lower lacrimal canaliculi, and this is the entry into the tear sac. So you want to make sure that you position this back before it contracts with adequate amount of balanced saline irrigation to make sure that the tissue is very well hydrated, and make sure that there are no corneal abrasions, and check with fluorescein dye test. The ophthalmologist does check it, and you do not want to apply anything on top of it. So this is a Crawford tube. It's called as, this is a silicone tube. You cannulate the duct. If you cannot find it in this case, which we could not, and then you open directly into the superior lacrimal punctum and then get it into the nasal. Dr. Dhawan, you were about to say something.
No, carry on.
This is as a, this is a partial thickness and full thickness explanation. You can have partial thickness eyelid injuries, that is anterior lamella is the other terminology for it. You can realign it just like that. Or if you have a full thickness test like this, and I could not find a monoocular stent, this is a bicanalicular stent. You can use it from the top and bottom, or there is a mushroom which you do not have to tie it like this. You can push it back. That's a monoocular stent or monica or whatever they call it. So with re-establish the nasolacrimal drainage, you want to do this fairly soon before it scars down, so that you do not have to go back for a big DCR later. So the avulsion can also be treated with, contralateral flaps from the top to the bottom. So you can raise a flap from the superior to the inferior if it is more than 25%. And then there is injuries which you treat, and then there is retraction of the eyelid. So this is buccal mucosa, the palatal mucosa which you use. Palatal mucosa, sorry, I misspoke about buccal mucosa. So you use palatal mucosa to lengthen the lower eyelid and put it back into position. This is entropion. Younger patients, if the scar causes entropion. Older people, they cause ectropion, that is lack of tensile strength, lack of strength in the collagen causes ectropion if you do a transconjunctival incision to treat any orbital floor fractures. So this is a patient of mine. You do big parotid tumors where you compromise the facial nerve, you remove all the lymph nodes, the skin and everything, aggressive parotid tumors. There you want to make sure that the eyelid, you put gold weights or the platinum weights on it, to make. Then there are another set of patients where just avulsion injury, like a ball hits this socket and that pulls the levator muscle. The levator palpebral superioris is one of the 7 muscles other than the rectus, 4 rectus and the 2 obliques, which is a sympathetic muscle supplied by, third cranial nerve. So that raises the eyebrow, and that raising the eyebrow, if you stretch it out, if you stretch the tendon out, just like how you see, this is the levator muscle. This is a textbook picture where the levator aponeurosis is stretched. Then they get ptosis. So this palpebral fissure, this is the fissure called palpebral fissure, the eye opening. It should be about 8 to 12 millimeters. Here it's a little less. So the patient is using her frontalis to actually elevate the eyelid. So that is the marking. So I had this patient awake, and you cut this much out, some amount of skin. This is a direct approach, called as a direct approach. You go to the levator aponeurosis, you trim a little part of it, put a central stitch, and then you go to the, and you put a central stitch exactly in the midline where the pupil is. When you mark it before, ask the patient to raise her eyebrow every time, so you know exactly where your stitch is going to be, and you hitch it back. There are multiple methods to do this. This is one of the way to do that. And of course, this is one of the major busy time for orbit treatment for me, especially, reconstruction, where there is ballistic injury. Ballistic injuries are the worst injuries, and you see a few patients now that causes any of this, any projectile of different velocities, and each one has a different yaw and a spin on them. So that gives you either the bullet fragments either there, you see this stars lighting up here, the fragments by itself can give you injury, or it gives you such a destruction there, then you lose the globe in most of the times, like, this penetrating globe injuries. You see the left side, the patient in the middle, the entry wound is here on the left temple coming out through the eye. And then this patient who's had a injury with the entry wound on the left nasal corner, destroying his NOE and coming out through the eye on the other side. So any patient, let me take this moment and tell you, any patient with orbital injury or eye injury, you still take care of the patient's airway first, breathing second, or circulation, make sure they're stable before you go to the eye. Eye is a secondary examination, but you want to make sure that the airway is intact. You see the middle patient, he had to have a tracheostomy because he would not maintain because of the brain involvement, intracranial compression. So of course, when you're doing all this, the patient make sure the patient's vision is accounted for. You don't have to treat them immediately. Ophthalmologist sees them. He has a full exam. You wake up the patient to see if there is vision. If you cannot wake up the patient, you need to still examine the reflexes, the globe continuity by imaging, enough intracranial neurosurgical input, nutrition, infection, and then you can go on, planning for this. You need to plan very well for these ballistic injuries. So you see this another gentleman who has a penetrating injury. He's destroyed the eye. I told you about evisceration, enucleation. He's got a intraventricular stent on the left side, so he's fairly unstable. So he's got intubation done. So airway is the important thing. So make sure you do have a role in the immediate sense, that is to make sure the soft tissues do not contract. So you hydrate the soft tissue, you clean them up, you see if there is vitreous leak. If the ophthalmologist does want to do it, neuro-ophthalmologist does help you out, or you come and repair the eyelids as well as the soft tissue injury. Make sure that at least some amount of semblance of cleanliness and hygiene is maintained. Again, just to revisit it, evisceration, enucleation, and exenteration. Exenteration is when the tumors are. So this is a time when we are eviscerating it. So you maintain the sclera, but you remove the lens because it's fairly protruding outside and completely non-functional. So you remove it with that scoop. It's cut off here. And so this is the picture I told you. And he's got a prosthesis here. And this is the intracranial defect anteriorly, which had reconstructed the frontal bone entirely. So the eye, so there is high stakes in this one. So we'll look at this. Again, do not put, this is a concept where there is significant soft tissue crush in the midline. So this is another patient without a seat belt hitting a tree. There was significant crush injury here. This entire nasal component, if it is a crush injury, crushing the entire frontal sinus and the soft tissues, be careful. And even the eye is still there, but apply a metal thing or something solid plastic. Do not put eye pads directly on top of an injured eye. This is another fundamental concept about taking care of a patient who's undergone a concussion, contusion, penetrating injury, or suspicion for intraocular pressure increase. So you want to put something as a hard plastic and to make sure that there is no compression on the affected eye. But you come back and treat the patient in stages again. First, you want to make sure all the fragments, the frontal bone, you go through the coronal incision, and then you get all the fragments intact. And I'm showing you two different patients here. There are multiple ways you can get the NOE component, and it is important. So if there is a crush injury, you do not want to put a wire fixation here. You want to use a nylon. I don't know, you see this nylon wrapped around this medial canthal ligaments to bring the medial canthuses together around a plate. So you want to make sure that is important. And if the patients are smokers, or if it is a salvage case, if somebody else is done before and you're doing it again, so make sure that you have adequate preoperative examination done. And you sequence the reconstruction then. So this is a patient, the same patient which I showed you with the crush injury. This is healed, as you see here, and you got exact NOE component compression. And this is where we make our segue into navigation. So we are recreating this eye socket. So you put a prosthesis inside, close the conjunctiva, and then you put a conformer. This is a transparent, a shell sort of a thing which maintains the fornix, bottom and top fornix, and then you suture that bottom to the top, which is a suture to the top so that you give no laxity or retraction of the eyelid. And if you want, I occasionally do liposuction from the belly and then instead of spinning it, most of you who have done fat fillers, you will know the Coleman fat grafting procedures for the face. You do not want to do spinning. I mean, at least I do not do spin it. I run it on top of a decanting a paper. It's called Telfa paper. So initially you keep rolling it and rolling it. So all the blood goes away and then you get fat, and this is a globule of fat. And then you run it between two syringes, and then you get clear fat, and then you inject the fat into the fat grafting. So that gives you the projection, and the projection, then she can go see a prosthetic person who would do a eye prosthesis. But this is a conformer they have to wear for about 2 to 3 months. So you get a sulcus superior and inferior pharyngeal sulcus is maintained. And she would still need fat grafting, but fat being, such a precious thing, and it dissipates, amount 50% is lost sometimes. But this is our outcome, So not bad. The superior sulcus is, this is like nirvana. You pray every day and you do your good deeds, and this is how you keep doing it and doing it and doing it, and then you see the right front lateral projection of the right eye is good, and the left is a little minimal. So I kept fat grafting her. But you keep small staged procedures. This is another fundamental concept in reconstruction of the globes. And of course, three-dimensional modeling. I use a wonderful three-dimensional engineer related model with injuries. 3D models are very helpful in contouring your understanding the defect. You can bend your plates on top of it, and then you can use that as mirror imaging from one side to the other, or entire complex to be understood. Or you can do your osteotomy, but it has limitations, the 3D modeling. So if you have lost everything here, the printer doesn't print every small bit of it. So you lose the amount of it. So here, the left side, the zygoma, the entire floor, the lateral wall, the nasal maxilla, entire thing is gone. So this patient didn't have a maxilla, the mandible was avulsed. I'll show you the picture of it, and the soft tissue component. So there is limitations for 3D modeling in such very severe injuries. And the limitation is when the tumor has eaten away every bit of the medial wall, the nose, the entire, this is the extraconal extension, of the entire bone is gone. So this is in-house modeling, but you cannot print it out because there is such poor rendition of it. Even same thing, most medial wall renditions are poor if there is a ethmoidal fracture. And this is the limitation again. If the tumor is fairly significantly good, I tried to put a scapula here and try to print a floor, it would not print really well. And this is a severe avulsion injury. The mandible is outside, and then you cannot print this model. So this is Rui Fernandez's paper on International Journal Medical Robotics about 3D rendering and the utility of it. But these are challenging cases. Just 3D models may not be enough. So this was the crush injury patient I was telling you about. There's no eye socket, there's no zygoma, there's no maxilla, there's no nasal bone, everything's gone. So how do we, so stage reconstruction and free flap reconstructions are the answer for those. But again, even if you have a model and if you use a titanium to bend it, this is a pitfall I'm trying to show you, which we deal with. So years ago, when you put a titanium mesh, so it looked like a golf ball here. So the soft tissue becomes atrophied, and you see it's like a golf ball, absolute golf ball. And then there are so many depressions, and then you cannot fill fat into this because the skin is almost tight, scarring to the tightly scarred to the implant, and then you have to put a fascia only free flap under that after raising it, or you can change it to a peak implant. But again, PSIs, that is patient specific implant or non-titanium implants, are good. Autologous bone grafts have a role in this here, but they can resolve again. And this is the concept about no amount of navigation, no amount of 3D modeling, no amount of one side to the other will give you the volume. So orbital reconstruction of the globe volume is unique. See this patient, I showed you earlier about a ballistic missile injury which had come out and destroyed his right eye. The soft tissues are draped well. This is a conformer. He's got great projection. The projection is beautiful. He's young, the fat was good, he was a non-smoker, and even from a bird's eye view, it is fairly good with the projection. So this is socket volume for prostheses. So about 3 months after this, this transparent conformer will come out, and then he will have an eye prosthesis, and you can move it if the enucleation, if the muscles have been maintained. So this is the same patient in an earlier stage, how we kept digging in the prosthesis to increase the depth. This is the eye prosthesis, the globe prosthesis inside. And I was telling you about the NOE component, how critical it is again, and the floor being reduced. So adequate amount of fat. So this is a fairly adequate amount of volume rendition anterior-posteriorly as well as by position. And then this is where you can use occasionally in such patients intraoperative CT scans. This is an intraoperative CT scan along with navigation. This is a face mask with all the 31, 33 fiducial markers which you use for navigation as well as 3D imaging. And this is the 3D model which helps us with the splint. The 3D models are excellent if there are multiple other injuries or if you want to take out a skull base access through the orbit. You see a deformity here, you're working through it. So intraop imaging, the pitfalls or the shortcomings of intraop imaging, just to reiterate, it's wonderful, immediate imaging is done and you can correct it, but it can be poor in formatting and the voxel production is less and you cannot contrast it, of course. And time wise, you spend a lot of time, draping the patient, bringing the CT arm, C arm, and then O arm, whatever they call it, and then having a intraoperative image. So this is an intraoperative image which I showed you earlier, and it was useful, to make sure that the volume is adequately good, especially if you wanted to harvest some more bone. So that is the end of penetrating injuries, the globe reconstruction. We are making a segue in a small navigation. I can talk to you about an hour's lecture on navigation. Navigation and mirror imaging, formatting, entire technology. The common thing I use without commonly available Brain Lab, Stryker, there are multiple ones. The Straumann, which is an implant, dental implant navigation, can be used for navigating if you jig it adequately enough. So in this case, you mirror image one side to the other by feeding a CT scan, which is done exactly to the protocol of what they want, and you mirror image to the other side, and to see if the post-operative result is good. And you can even use that CT to fabricate a patient-specific implant too. So I'll show you a few instruments. This is the face mask type, which has got a infrared sensor here, and you see this is the suction tip, or you can use it on any tip. And this is the suction tip, as you see. You can use that. That's the navigation tip here, and that tells you exactly where you are. And there are various platforms. You can use multiple ones. This is from the one which I commonly use, which is a face mask, a 30+ fiduciary markers. You mark everything, but the problem with this is you have to have your cranium, your frontal bone, everything intact. You're working only in the orbit. But what if the left side of the brain is missing, left side of the skull is missing? I'll show you a few patients. And then you cannot use this entire face mask. Of course, you can cut part of the face mask. You can only a few fiduciary markers, but that increases the accuracy or decreases the accuracy to a certain extent. And it uses the LED technology, and it does not have any radiation at all completely. So it's fairly simple. You can keep it. This is from their website. You can use it. And I create what is called as a no-fly zone. I put the optic nerve, mark it before, and anytime I go near it, it would give me a beep. Or 3 millimeters close to a blood vessel, I put a no-fly zone. It gives you a beep. This is used in neurosurgery, and it is not purposely made for me. What I'm trying to show you is, this is the patient which I used along with the neurosurgeon. This is the orbital apex where there is a huge foreign body of a ballistic missile again, a bullet piece. And I was trying to mark it, and the temporal frontal lobe of the brain was right there. So I didn't want that to be pushed upon or impinged upon. So I was trying to get this out with this optical navigation. So there are corded ones, non-corded ones. So there are various platforms. That itself is a lecture. There are multiple papers, multiple units who contribute their entire life on that, but you can keep doing it. And there is a lot of papers from different units based for navigation, and you can learn from them actually. The Germans are fairly good. The Brain Lab comes from Germany, and those units, I think Amit is from Hanover unit, and that unit is fairly good at navigation, right, Amit?
Yes, Srini, the Professor N.C. Gelrich is there, so they do a lot of navigation surgery there, and
navigation. It's phenomenally good, the amount they produce, but luckily for Germans, they don't see like the ballistic missile injuries, and this is endoscopes. Endoscope is another adjunct. Along with navigation, you can get another view or increased view. So the guy who would endoscopic thing, when I was at Seattle, Chris Moore, he's got multiple publications. This is his. You get another view, around the corner. You can check the implant, and I constantly use endoscopes now, so that I can look for where the implant end is. This is the patient which I was telling you about. So you can create, again, model-specific implant, and I sit with the people and I plan significant, just for the interest of time, I will say how I plan the implant. Everything is custom made. This is a custom patient-specific implant of PSI. So huge defect. The ear is gone, the mastoid part. From the mastoid to this maxilla, there is nothing. The entire cranium is gone. So I create a huge implant, and then you brush it off. I work with the biomedical engineer, wonderful people. I learn from them in most of the time. They're more intelligent than stupid surgeons, but not me, not you guys, but me. So I learned from the biomedical engineers a lot. But we create a huge implant. You can section the implants, and you can the cranium to the orbit to the maxilla. You can section each one of them, and you can fit them apart, so that if there is any issue, you can trim them. Use a saw and trim them. These are peak implants. You want to make sure adequate amount of heat is not generated when you cut them. They can melt, and then they're fairly good, unless, of course, if they do not get infected, they're pretty good. The porous quality, and so this is the implant. I sectioned it, intraoperatively, the lateral orbital wall, the zygoma, and this was the patient, meaning he had a huge defect. If you notice the previous one, I had put a tissue expander on here, expanded his scalp, and I rotated his scalp to cover this. I've overcorrected it because I want this to stretch so I can hitch this up. This is what happens if you do not address the soft tissue things immediately. They shrink and the entire eye is gone. It's very difficult to get that eyelid function back. Some compromises, but at least there is no CSF leak. He's got bilateral contour, and he looks symmetrical compared to this one here. This is the same patient. So I was showing you in this one another model, and then in navigation, the most important thing if you want to do or take care of the patient is you want to position the patient where you don't have to pin. Most neurosurgeons would pin the patient because they use brain lab or one single point. For us, it's a three-dimensional. So you do not want to pin the patient. This is what I learned. This is a universal frame, and most neurosurgical units have this. This has got two seats, like where contoured, where the head can shift, and you can move the patient around, where the head can tilt around. So this is the most critical thing. So this is a universal frame if you ever want to use it. Do not pin the patient, and the horseshoe may not help you either. Sometimes that impedes your access sometimes. And fiduciary markers, that is I told you about the face mask, right? About 30 fiduciary markers. Fiduciary markers are the markers which you mark initially so that the computer picks up as the representative, and then every time you move away from it, it gives you an alert. So that is the fiduciary marker mask, or you can do splints, screws, a lot of things. But you want to keep that fiduciary markers, patient specific also. And then good imaging. You want to get a good image, 1 millimeter cuts, and multiple formatting, and to make sure that, for instance, the Stryker have their own thing. I'm not selling any product, anything, but I'm trying to tell you, each one has their own protocol, and that reduces the error reduction significantly. So I cannot emphasize on this more than enough. And you can use your neurosurgeon's navigation significantly. So I told you there are different markers. In this one, there is one skull point which you drill into it, and then this infrared camera picks it up. And in this one, there is a mask which I showed you earlier, and there is an infrared camera on top of it that picks it up to no radiation. So again, you can combine it with an endoscopic procedure for skull base access, and you can use different instruments. And as I've listed here again, you want to make sure that there is proper protocol followed, formatting. Be friends with your radiologist, and you can create a protocol for yourself so that you do not have to reinvent the wheel. That means, you make it a ongoing thing for every case, and then the patients have to be positioned in a neutral position. I told you about the splints, mirroring, and in-house versus industry. And this is about navigation and PSIs, and we'll make a segue into a couple of things if you're interested in how a maxillofacial surgeon can become a skull-based surgeon by training yourself. This is a cadaver which I've dissected. When you go to the cadaver lab, do every bit of osteotomy you want to do, and that's how you do an answer. Maxillofacial surgeon, the skull-based surgeon of the future. We presented it in Rio, saying how we've trained ourselves to be skull-based surgeons and how we can become a skull-based surgeon. And then this is because there is a lot of tumors which come from the nose, the orbit, the nasopharyngeal area to the pterygopalatine, which goes into the brain, like how you see in this one, or from the infratemporal fossa, which comes through the foramen rotundum or through the pterygopalatine again, and then they come into the orbit. And these ones have to be, this is a cartoon from Mayo presentation. So they have different pathways. The fourth one, if you look, foramen rotundum canal, and then that goes into the brain. And this is where, number 3 is what I wanted to tell you. Pterygomaxillary fissure from the nasopharyngeal into the masticatory space, the infratemporal tumors. So that gives you a significant amount of, let me see here, a second. That's how it spreads, each one of them, and then the cartoon. That's a lot of cartoon, so I'll skip that, as I told Dr. Dhawan. And this is one of our case where I told you about the facial vasculature in the first picture I showed you. This was a case which we did for the neurosurgeon, where we accessed the skull base through the orbit, which was with the angular facial vein. In the corner of your eye is angular facial vein. This is what is called as a carotido-cavernous fistula. So the carotid and the cavernous sinus have a fistula, and that is causing a significant amount of vein engorgement here. This is a superior ophthalmic vein on top of the musculature in the right orbit. So there is backflow, and the patient gets severe amount of proptosis. The eye gets projected out. Chemosis, that is a conjunctival edema. The patient can have significant amount of pulsation sometimes. So I access this skull base access, which I provide to the neurosurgeon by accessing it through the eye. You see the bottom right picture here. I did a superior blepharal incision, and then got up to the roof of the orbit, where you get the superior ophthalmic vein. So you put, just like you do your control of your external carotid with your loops, so vascular loops, I put 2 loops on either side and cannulated that vein so that the neurosurgeon could come in and coil this area here. You see the vein here, a 3D rendition, and it's here on the CT scan in the axial section. So this is a superior orbital entry, and this is a cavernous sinus where the platinum coils are used to embolize that. I mean, so this is a carotid cavernous fistula. This was a patient. So this is the pitfall afterwards. So because I did an access there, the eye would not shut completely, and there is some amount of conjunctival injection from before. And this is the patient with what you call as exposure keratitis. So this is a concept again. If you don't close your eye with adequate amount of tear film, so your eye conjunctiva gets exposed and dry, and it pops out like a balloon. So what he did was, in the clinic, put some local anesthetic on the top and bottom and stitched up the upper eyelid to the lower eyelid. And you see that suture being, this is a frost suture, which is called as a frost suture, and you tape it up to the forehead. So then in a few days, when your eye, your conjunctiva, which is prolapsing here or herniating here, would reduce, and that causes normalcy, meaning the swelling is gone. You will see the incision here, the superior bluff incision for the superior ophthalmic vein axis on the roof. So exposure keratitis. Then you get these patients who've had nasopharyngeal carcinoma, who've had radiation, and the radiation causes significant osteonecrosis. You see, it's called as the empty syndrome. Here, there's nothing in the middle. So the mucosa is gone, all these bones are exposed. This is a carotid here. This is the petrous carotid, carotid, and this carotid can cause bleed occasionally. And this patient had bitemporal hemianopsia, meaning you could not see on bitemporal vision. He loses bitemporal vision because of the optic nerve being affected, the chiasm being affected. The bleeds are because of the internal carotid being desiccated and osteonecrosis in this region. In those cases, on a skull base, you see the palsy of the right eye. We raise the temporoparietal big flap, and you tunnel that with a Cook catheter. This is for just widening, just like a dilator, and you tunnel it into the right maxilla, and then push it into the skull base. This is the endoscopic view, which I took an endoscopic picture. You look at the skull base. This is your sphenoid, which is empty, and then this is your necrotic bone, and your carotid is right there. I mean, this carotid is right there, and this, if you, the bleeds, very terrible bleeds. Even if the patient coughs, the flap would fall back. So that is another skull base procedure by a maxillofacial surgeon to increase the blood supply to the skull base for osteonecrosis. And then, of course, again, you can use the same navigation to go through the posterior orbital wall. Posterior orbital wall, you go into the middle part of the mid fossa of the intracranial cavity. So any tumors there in the Meckel's cave or anywhere, you can use that as an exposure for the neurosurgeon. This is, you use a nerve hook or for the endoscopic resection of that posterior wall, and then you expose the nerve with loops. And this is, how you do it. This is for tumor ablation. I'll show this patient who had a huge tumor, again, going from the nose, the palate. This is the roof of the orbit. And the cribriform, there was a little bit of CSF leak before we obliterated it with the flap. So you know this anatomy fairly well. The ethmoids are gone completely. This is the publication for providing intracranial blood supply by a sternomastoid flap when in moya disease with the neurosurgeons. And this, you keep assisting them, and they'll let you borrow all the navigation material as well as the intraoperative CT scans. That's how you make it happen. So neurosurgeons are your best friends if you can want to do orbital reconstruction. Of course, now we are making a segue into the final few slides of orbital tumors. Orbital tumors can be a lymphoma, like in this patient. So, but they cause significant amount of globe malpositioning and numbness around this area. obstruction of the nasal cavity, I told you tearing, the obstruction of the lacrimal system here can cause epiphyseal of the bony part of it. But the common things in my practice, what I see is metastatic tumors. Metastatic tumors are tumors from the nasopharynx, the sinus, the nose, from the palate, which goes through into the eye, meaning there are extra-orbital tumors which invade the tumors. But there are intraocular tumors too. If you see, in children, rhabdomyosarcomas are common. Most common pediatric orbital malignancy, that is the embryonal subtype. This is for the postgraduates. Rhabdomyosarcoma, I mean, around 8 years of age is the most common, 5 to 8. Male kids more problematic. And they are very aggressive, fairly aggressive, rhabdomyosarcomas. I mean, so you want to watch out for that. And retinoblastomas, if you do a CT scan, or if you do if there is calcification inside the eye, it is a retinoblastoma. It can have bilateral tumors, just like these uveal tumors, or even retinoblastomas can be bilateral. So most unilateral tumors are metastatic diseases or extensions, or I mean, there are rare lacrimal tumors, of course. I mean, lacrimal tumors are common, meibomian gland tumors and other things. But the ones which I have seen is breast, most common, metastatic tumor. The patient has had breast cancer. About 5 to 10 years later, she develops a double vision and retraction. You know, they get diplopia, I mean, most common thing. I'll show you a patient of that. Of course, lung, bronchial carcinomas, prostate, renal cell carcinomas, thyroid, melanomas, intraocular melanomas. This is an intraconal tumor inside the cone. That is a melanoma. And of course, there are other sarcomas and extensions I told you. So this is a patient with a adenocarcinoma of the frontal sinus, which is meaning invading the entire cranial cavity. That causes that you see the right side lacrimal sac as well as the orbit is being affected. This is a malignant peripheral nerve sheath tumor with some amount of presence here. I mean, this is not very aggressive, but it can turn into a sarcoma fairly soon. It's a low-grade sarcoma. I mean, we are writing that up. And then, so here again, you can do CT scans to see the bony architecture and fine thin cuts. Again, you can do other things. But quick assessment, 3D resolution is good. And you can do MRIs. MRIs are important. MRIs, in this case, you see, you can differentiate between a primary versus a metastatic tumor, an infiltrating tumor versus an advancing tumor. And PET scans are useful too. And PET scan, you see the left orbit lighting up. That was a tumor presence there. And you see the intraconal tumor here on the left side. You know, this is a tumor, you see, this is the right side, the optic nerve and the fat around it, and this is a tumor here. I mean, all this patient had was minimal amount of diplopia, I mean, double vision, because they small, like a scar tissue, and they're very subtle in growth. Of course, we see this all the time. Skin tumors are so advanced, and you know, melanomas and squamous cell carcinomas, they invade the entire orbit cavity. This patient, I'll show you the other side. I mean, you get an advanced stage presentation. I mean, all you have is complete mid-phase resection and reconstruction. In a post-radiation, they do fairly well, but you know, for 5 years survival rate. Or regional spread. In this patient walked into the emergency room, which I saw him. You see such a subtle presentation. All he came was for bleed inside the mouth. But you see there is fullness of the left cheek. The left eye is proptotic, and there is some amount of palpebral pressure changes. And then the patient had, I mean, this may not be an emergency room phone picture, but this was a tumor sticking out. And this is again a skin basal cell carcinoma, which invaded the entire eyelid and the lateral orbital resection. I mean, the entire globe had to be resected. And this was the patient which I showed you. I mean, aggressive tumors, I mean, the left eye, the right eye, as well the right ear. And you get post-radiation eye tumors too, meaning malignancies, secondary malignancies. This was a publication, and this was a bony lesion which radiation caused sarcoma, and then we had to, it's invading, eroding the eye. And another concept here is Weber-Ferguson incision. Weber-Ferguson, anytime you do a Weber-Ferguson incision into the infraorbital extension, the Dieffenbach extension, it always causes some amount of retraction of the eyelid post-radiation. So, in fact, the Bangalore group, meaning, the Dr. Nair and Anjan Shah and Kumar have a beautiful publication about infratemporal extension or the infratemporal resection through mandibulotomy. You do a mandibulotomy and you do skull base axis here. That's a good paper if anybody wants to read it. So orbit tumors management, you either preserve or resect whatever is thing. Of course, review the invasion by MRI and a CT scan, sometimes both, or sometimes even a PET CT scan, and look for fat versus mucus. Inspissated mucus amount will occasionally look like a tumor. And then you decide the muscles, then the infratemporal fossa and the fissure extension. Then Dr. Moni Kuriakose the other day had a beautiful pearl in one of the AOMSI lecture about once the orbital apex or the superior orbital fissure is involved from an infratemporal fossa, that is the end of poor outcomes. That is the beginning of a poor outcome. So you want to be careful about that. And periorbital tissue, if it is resectable or not. So you want to go through the fissures and the dura, and this is the MRI I told you about. Bony invasion or extension to the orbit, tumor involvement in the fat in here. You want to see if it is complete extraconal resection or an intraconal, So exenteration is a common outcome most of the times. But anyway, here you see another tumor with a metastatic deposit of a breast cancer. And that was one of our patients. And this was a patient which I took care of, a solitary fibrous tumor, extraconal. It is from the lateral wall extending. We got it embolized, and I did the lateral osteotomy, and then I got the tumor out. You see the proptosis in this patient, and then this was the resection, lateral resection with a lateral canthal and a subciliary approach. This is how we presented initially with injection. So this is a beautiful paper if anybody wants to read it. It is by Rotan. Most of the pictures which I've used is from a neurosurgery lab in the University of Florida. The patient is, the Professor Rotan is no more. He died a couple of years ago, but the entire dissections are available in his museum to use for teaching purposes. So this is a concept about intraconal and extraconal. So intraconal meaning inside the periorbita. It can be lateral, central, or medial, or inside the like extraconal area, but intradural versus extradural. So extradural is easy, lateral canthotomy, but you still can preserve the entire orbit and the fat and the eye subunit. So this is what happened here. So that's a representation. This is how I use navigation. You see the posterior projection of where the margin I had to get. So the margin clearance was good, and then you use the navigation. This is the neurosurgical brain lab navigation, intraoperative, lateral rim, and the preoperative embolization. So that is the tumor. You see the lateral, how it is the shelling out tumor. And then the final few slides about reconstruction. So reconstruction, when do you have to reconstruct? You reconstruct for fractures. You reconstruct for missing bones with autogenic, allogenic, as well as soft tissue involvement. So it could be traumatic, you have the lid. If you lose the lid, it is fairly difficult to create anything as a palpebral fissure, and the missing soft tissue of the cheek has to be reconstructed. So the more the bulk, there is some gravity which affects you. If anybody has to read this, these are two papers in my library. I always go through them if I have to teach anything. This is by Carlos Suarez and a multi-unit European paper. It's a beautiful paper, and then it is about the management of orbit in malignant sinonasal tumors. Fantastic pearls in it. And then there is the other one, Doug Chipeha. This is in laryngoscope too. So this is a beautiful paper about restoration of the orbital aesthetic subunit in complex mid-phase defects. I mean, Dr. Fernandez always tells you the pearls in this. And this is how reconstruction or restoration of a orbital aesthetic unit happens. You see here in the highlighted things, and I've made the gist of it for you. Skin grafts. I mean, I would not use a skin graft if a patient is going to go for radiation. I mean, if it is a temporary lining, it's good. Local flaps are good. I mean, and regional flaps like the cervicofacial flaps, the temporalis system can be used, but it's limited. If you're having radiation, again, this will melt away. But the distant flaps, if the patient is going for significant bulk, and when to use a radial forearm, and when to use anterolateral thigh, and when to use a osteocutaneous is, if you lose more than 30% or more than 2 walls, you want to use an osteocutaneous. I'll show you a patient in the next couple of slides about when to use osteocutaneous one. But you see the pitfalls of reconstruction after tumor exenterations. You see, the flaps, the bulks is completely gone. The bulk is atrophied after radiation. So you get this defects, which are, you can get osteonecrosis, like I showed you, retraction, multiple flaps, and, even then you still have a defect. This is fairly debilitating, my heart goes out to, reconstruct these patients who have gone through so much. So this is the radial forearm patient. I mean, this is how Dr. Fernandez does it. I mean, like if there is a defect, he keeps putting the sticky tape, and then transfer that onto the forearm, and then the defect is. This is only where there is soft tissue only. There is no orbital rim involvement. There is no bony involvement or limited bony involvement, less than 30%, less than 1 or 2 walls. It's beautiful, magic. And then it is a fasciocutaneous flap. But if the patient, in this patient, I lost for resection, entire nasal wall, entire zygoma, maxillary rim, and the zygoma. And fibula is not an answer, certainly not an answer. I mean, because you get this secondary defects, which you need to maintain that bulk, but you do not get the rim thing. The best flap to use, this is a patient, similar patient I showed you, osteocutaneous radial forearm free flap patient. If you ever want, I can walk you through the, so this is the zygomatic component, and this is the maxillary component. Only drawback of this osteocutaneous radial forearm is you cannot do multiple small osteotomies, but the rim, it beautifully sits in the lateral rim, it sits in the inferior limb, it sits in the lateral nasal wall. You see this perforating thing as a inverse contrast enhanced post-op. So this is the entire flap. This is when you lost everything. This is when this patient came to the clinic with an ill-fitting denture. So he had a huge squam, entire palate involving this part of the floor. He had significant amount of epiphora and obstruction of the nose. The ethmoids were gone anterior, then the nasal complex was gone. So you see this is all tumor. So he had a total maxillectomy, a majority of the nasal complex, ethmoid complex, and then exenteration all the way to the apex, and then floor resection up to the zygoma. This was, the plan. This was an intra-op. Our fellow did this, plan. This is the resection margin. So this was the outcome. And then we did this a few months ago. And then this is a complete resection, the palate, and then coming out through the cheek and the nose and the eye. And then this is preoperative planning with the scapula. This is the scapula. This is the subscapular system. This is the entire latissimus. This is the parascapular skin. And then you put the scapula for the palate, and then stuff the entire latissimus into the, I showed you CSF leak here. So you stuff the entire CSF and the skin paddle sits to the outside. So this could not be printed very well. You need a good printer. So in-house printers may not do this job. You need professional help in these patients. And then this was the patient. Again, I told you it's a chimeric flap based on the subscapular system, scapular tip, latissimus, and the parascapular skin. Say, and this is the patient. So we give oxygen directly to the flap. So that is what finally you try achieving, some amount of reconstruction in an orbit. So, but the verification of accuracy in every step is important. And, it's all measured by the root mean square error in navigation and the outcomes. So this is the patient. I took multiple small steps in this patient. She was very compliant, and we got this. There is a little more 2 millimeters of levator hitch to be done and some amount of fat, but finally you get there, from a complete, collapse of the midface. I mean, you get there. And again, thanks again for listening to me, a humble presentation of my experience with some representation of cases. If there are any questions, I'm more than happy to spend time with you.
Thank you. Thank you. Yeah, it was a very extensive and wonderful presentation by you. As of now, there are no questions, but I just want to ask some questions to you. Dr. Jagdish, do we have some time for the discussion?
Yes, Amit.
Okay. So Srini, quickly, I just want, for the sake of postgraduates, can you elaborate your views on the orbital trauma? What kind of surgical approach you prefer to access the floor, lateral orbital wall, as well as the medial orbital wall? For the sake of postgraduates, if you could spend some time in explaining this.
Yeah, it's a wonderful question, and you, as a surgeon, I want to think about it every time I approach a patient. So the options are multiple. These options are transconjunctival is my go-to for the floor and even the lateral. I release the canthus on the lateral surface and then rehitch it back. And I have medial canalicular extensions sometimes. And this works most of the time, transconjunctival. But of course, there are patients which you cannot use transconjunctival. Then I use a subciliary is my next go-to. And if there is a laceration in any of the subtarsal or the infraorbital, I use it for my benefit, but I do not use that as a first choice. But those are the other ones which I mentioned too. And even in transconjunctival, occasionally, if I'm alone and if I think it is an isolated thing, instead of going preseptal or postseptal in the transconjunctival, I use a fornicial incision. I retract the globe, I press it on top of to the bony rim, and I go directly onto the fornix and then go down there.
So that is a variant.
I hope I answered the question.
Yeah, that is a variant or modification of the postseptal transconjunctival incision as well, isn't it? So, so your choice of surgical approaches are transconjunctival. I completely agree to that. And what about the medial orbital wall? What all extensions you do for the medial orbital wall reconstruction, and what structures you need to preserve when you go towards the medial wall for the reconstruction of the medial wall?
Medial wall, I occasionally incise the canthal ligament, and canthal ligament you have to suture it back, and that's very important. And canalicular incisions are very well described, and it is a beautiful incision to go through. But if I have to go very further away, as I told you, I am very cognizant of the anterior ethmoidal artery and the posterior ethmoidal artery. Where is your entire quadrangular plate of the ethmoid is where is the medial wall. And occasionally, if it is collapsed completely, I put a small vascular clip on each one of them, or I take a bipolar forceps and buzz these two, and then I open up the entire septum. It's the easiest one to open, actually. People say lateral is easier, but medial also can be efficiently done.
Yeah, very nice. So now regarding the reconstruction options for the orbital floor. So what would be your choice of material? Like, would it be bioresorbable, or would it be a radio opaque material which is not bioresorbable, or would you like to go for an autogenous a bone graft for the orbital floor reconstruction, or is it a customized kind of a reconstruction which you follow for each patient, or or you have evoluted, for example, from past 5 years or 10 years if you are doing orbital trauma, and how did you gauge your evolution in orbital trauma reconstruction, that 10 years before you were doing something else and now you are doing something else? I want your views on how to choose a biomaterial for orbital reconstruction.
It's a loaded question, Dr. Dhawan, and thanks.
So I want you to tell me briefly for the sake of postgraduates.
Yes. So evolution has happened. When Tessier taught, and the school of Tessier, the people who are trained, Joe Grass. I used to work with Joe Grass, and he would walk into my operating room and tell me about how to adapt the calvareal bone and other things. But I do not use autologous bone for floors unless I do not have anything else. Titanium works beautifully well, and multiple modifications of titanium. So over the few years, I've certainly evolved after I've done multiple cases which I had to do my own cases redos, and multiple other people's redos. And I make sure I cover my titanium with a small bioresorbable. It can be even your temporalis fascia or fascia lata from your thigh, or if vicryl sheets, polyethylene sheets, which you cover, and that gives you the slope. One of the picture I showed you with the implant, that gives you a separation of the radio opaque material of the titanium, plus the movement without the fibrous capsule, if you have to ever go back, and a small sheath on top of it. That is my go-to currently. I've stopped using MedPore because many of these patients smoke, and for some reason, smokers and infections are fairly high. And MedPore is not fun if it's infected. So that's a short answer for a long question.
So there is a question.
And for the roof.
Yeah. Please go ahead.
Sorry, for the roof and the medial wall, I've occasionally used autologous bone, and I've used fragments many a time for the rims.
Great. So if you don't want to use bone, and if the situation is that you don't have, like in Indian scenario, you have not planned a titanium mesh for that, just to correct the orbital volume, do you have any soft tissue options, like any cartilage or any fat or any fascia or anything? Like, what is your choice for soft tissue, just a volume correction of the orbit, and you don't want to correct it with the bone and any material you want to put in? So what is your choice of material for that?
Yeah, I love autologous fat. And most of my autologous fat, as you saw, I showed you, the technique is, I use fat in small increments, even in radiation patients. Occasionally, I use with the dermal fat, with the fascia intact, and that stays there for some time, rather than like multiple small amount of injections. This dermal with the fascia intact, the fat attached to it, and I lay it like a spindle shaped, and that really helps. And cartilage is not something I use unless there is a eyelid injury or something which I'm trying to give some amount of support after cutaneous cancer excisions.
Okay. So there is another question. What technique do you follow, or what will you do, how to protect the infraorbital nerve injury during floor reconstruction? What all things you want to give tips to the postgraduates? to prevent injury to the
The best tip I could give the postgraduates is small instruments and put like some gel foam or something as you're exploring if it is bleeding too much. So vision as well as small instruments. You know, the small amalgam burnisher, which we
Yes.
used to have with the flatten. I use those instruments, you know. I have my ENT colleague actually picked up from me those instruments too. So we use small instruments so you can, or a nerve hook is very good. A small nerve hook, so you can put this nerve hook, gentle retraction. You know, the flat end of the it you can do for elevation of the flap, and small malleable retractors. So this is my technique. And you know, neuropathies, you know, the neurosurgeons, you use
Yeah.
small neuropathies, you place them adequately enough. And I try not to put any medication in it. I mean, occasionally I've done epinephrine and other things, but that gives your pupillary, you know, changes. But you stopped using those, you know, Afrin, the oxymetazoline and other things. But if there is sinus mucosa, I pack it there. And then I look for the nerve. I mean, actively look for the nerve, and I protect it. I mean, if I can. And that's the best way to do it. I mean, you know, blindly doing it, hoping the nerve would be intact, may not be, I mean, you know, in better thing to do.
Yeah, great. So are there any situations where you in the secondary post-traumatic deformity where you need to overcorrect the orbital volume, and because you are anticipating some atrophy of the soft tissues, or the conditions in which you need to undercorrect the orbital volumes in the traumatic deformity?
I always undercorrect, take small steps rather than overcorrecting. Only time I overcorrect is the roof, and if I know that, you know, I'm not going to mess with the dura again, and if I do major resections, I overcorrect for radiation. I put a lot of bulk for radiation so that the bone never gets exposed. But that has put me in trouble sometimes, like, you know, the ALT or even the LADAR size, they sag because of the gravity, you know.
Yeah.
So that's the only time I overcorrect. Undercorrect, you know, traumatic defects, I usually undercorrect them slowly. But
Great.
I check if I can immediately.
And regarding the reconstruction of for the orbital tumors, as well as when the skull base is also involved, uh, uh, is
Yeah.
there any other pedicle flap, like we used to do Haddad flap for Haddad pedicle reconstruction flap, which is a posterior nasoseptal pedicle flap when we used to do
Yep.
reconstruction of the skull base. So have you used that, or what basically flap is the like your choice of flap for that kind of reconstruction, where you need to reconstruct the skull base as well as medial part of the orbit, soft tissue reconstruction? As one of the cases you have shown that
So
there was, yeah.
yeah, I mean, yeah, I mean, I did that best one for you, you know, Dr. Daman. When you kindly asked me to do that for your Amritsar meeting, I did every sort of flap for you to
Yeah.
make sure that I presented a video for you.
Yes.
But you know, nasoseptal flap is a wonderful flap to do, and it occasionally meaning, but I leave it that to the ENT guys. But I do inferior turbinate flaps. I do. You know, septal flaps, even buccal fat pad on a lateral resection. I've used that as a skull base uh, placement, and I do temporalis. Most of the time, I end up doing free flaps for those.
Okay. So when you do orbital exenteration and when you do enucleation of the eye, well, like with your prosthodontic colleagues, when you work, what are the best possible ways to reconstruct the eye as a prosthesis? Like, do you have any soft tissue
Um,
considerations before that when you are going to resect? Like what structures to preserve and what structures to leave?
So the best structure to leave is your eyelids. Eyelids are something which are never you can recreate. Lips you can recreate. Eyelids are something which are very difficult to recreate. So
Yes.
I try to see if you can leave the eyelid back. So that is not a total like you're talking about even extracorneal extension
Yes.
tumors. You can leave the eyelid, and that is wonderful. And if you can leave a little bit of the towards the apex, some amount of support, and you can hitch the globe back in, that would be wonderful. But you see in the challenges which I've shown in every patient, it is almost there sort of a thing. You're doing constantly keep refining it. Eyelids are the thing which I would leave.
Yes. Are there any questions from anybody, Dr. Jagdish? Anybody, and if you want to ask any question to Dr. Srini?
Nothing actually. In the chat box, no questions are there, I think.
Yeah.
I saw a few, all of them you've answered, the floor
All
and
those
other
things
things. Yeah,
Amit has discussed with you.
Yeah. Thanks.
So, are we calling it a day, Dr. Jagdish, or are we taking some more questions?
I don't think there are any questions that is being posted.
Oh, great. Okay, right.
Even
Sir.
in the YouTube link also, there are no questions.
Okay,
Yeah.
right, sir, right. Yeah.
So,
So,
thank you, Dr. Srinivas, for this wonderful presentation. And I presume that you have cleared many doubts in the young surgeon's mind. And on behalf of the department, I wholeheartedly thank you for your commitment and efforts to make this a difficult subject, to make it understandable in a simple way. You have touched upon all the aspects. It was a very nice presentation, and I thank you for that wonderful efforts.
Appreciate the opportunity. Thank you, Dr. Jagdish.
Also, Amit, you have
hope
done
it
a
was
good
good
job.
enough.
You have handled this session beautifully. It was a great work. Thank you so much for your time and commitment.
thank you so much. Thank you so much, sir. And Srini, I just wanted to add a point for appreciation for you, that I have learned so many new things in your presentation today, and like you have been doing a great work, and a lot of reconstructive options which you have shown, and I must say the resection techniques, and they are very clear, and almost everywhere you have gone with the clear margins. I'm very sure about that. Just one query for orbital tumor. Do you always do the margin mapping, or is there any other modality you use, like immunohistochemistry for margin evaluation, or just a histopathology for margin evaluation?
Just histopathology, and I go wider than some critical structures, the cribriform transgression and other things. I always have my neurosurgeon with me if needed, on call if necessary. And I've certainly embolized some tumors. The one with the eye I showed you, that could bleed, so that I'm prepared enough. So such things preoperatively. So many of these T4 tumors, that is, do end up with radiation. So how much of a margin you do get because of their destruction or extra extension, you do get radiation to them.
Thank you.
You keep trying. Thank you. I appreciate you, and you do a great amount of work too. And Dr. Jagdish, you humbled me. Thank you.
Thank you. Thank you so much.
I want to thank all the delegates for their involvement and participation. And for the delegates, please fill in that feedback form that is given in the link, so that you can receive a e-certificate of participation. Once again, thank Dr. Srinivas and Dr. Amit for the efforts and
Thank you.
commitment. And hope to see you all soon again in this sessions.
Thank you all.
Appreciate it.
Thank you.
Thank you.
Thank you.
Stay safe, guys. Bye.
Thank you. Bye.
Bye-bye.